everybody, my name is Amber Moore and today I'm going to be doing my presentation on pneumothorax. So first, a pneumothorax is just a collapse in the lung. Basically this happens because of a thoracic injury of some kind. What occurs is a buildup of pressure in that pleural space in between the lung and the chest wall. So it could be due to a pocket of air, it could be due to an injury. Either way, these are reasons for getting a pneumothorax. So there's different types of them, and those classifications are just kind of dependent on what happened prior or along with that collapse in the lung. So for an open pneumothorax, that normally is when something comes through the chest wall from the outside, so like a gunshot wound. So if someone were to be shot, it would come in through the chest wall and then interrupt that pleural space, creating the collapse in the lung. With a closed pneumothorax, these are a little trickier and they might happen spontaneously, so they're also known as spontaneous pneumothorax. But it's just because we don't know of the reason for why it happened. It's not normally very apparent. So those are caused by a little pocket of air that sometimes forms on the lung, and those are known as blebs. I didn't know what that was, so I had to do some kind of research to figure it out. But here's a little picture to kind of show you what it is. So that's that pocket of air on the lung there. And if it ruptures, that creates a collapsed lung as well. But there was no disruption in the chest wall at that point. It just kind of happened within the chest wall. So that's why it's called a closed pneumothorax. You'll also hear of iatrogenic or traumatic, and those are just due to trauma. They're kind of interchangeable. And the one that you want to look out for the most is going to be a tension pneumothorax. So with those, we have an increase in pressure, and it's because the air cannot escape. So if we have any suspicion that a patient has a tension pneumothorax, we need to get the medical treatment right away because there's an increase in pressure on the heart, on the lungs, on the blood vessels. This decreases our venous return and is very scary for the patient. So we need to just keep an eye out for that. So for our modifiable and non-modifiable contributing factors, of course non-modifiable is going to be smoking. Modifiable, on the other hand, is going to be lung disease, like with COPD. COPD patients, our previous pneumothorax patients also might be at risk at this point because there's a 50% reoccurrence. If you've had one before, you're 50% more likely to have one again. If you've had any mechanical ventilation, and the one that I found the most interesting was actually the genetics. So under genetics, you'll see there's new research out that if you have a mutation in the folliculin gene, which the folliculin gene is just found all over the body's tissues, but at the lung tissue specifically, its job is to repair and reform damaged lung tissue. So if you have a mutation in that gene, you could be predisposed to a spontaneous pneumothorax. For our list of typical signs and symptoms, we have a rapid heart rate or increased heart rate. You might see them turn blue. They might be confused or dizzy, have a loss of consciousness. Increased breathing rate or shortness of breath. It just kind of depends on what's happening with that patient physiologically. But normally anything that you would think to see with someone who had a loss in that oxygen supply is what you're going to find with these patients as well. For our effective management strategies, what we're going to find is that needle aspiration and chest tubes are the most common. With needle aspiration, they're going to aspire the air by inserting a needle into the second intercostal to re-expand the lung. With a chest tube insertion, they're going to just drain the air from around the lungs. Within 5 days, if they haven't seen an improvement at this point with re-expansion, they might consider surgery. So a thoracoscopy is one that they consider, and this is just to look into the chest wall outside of the lungs and see what's going on. And then depending on what they see there, they might do an electrocautery. So an electrocautery is there to ablate any of those blebs that we talked about earlier. And if they are able to find them and ablate them, that could help the patient out as well. So management and physical therapy interventions, our job at this point is just to get the patient's lung capacity back up and to help them train their muscles and their body at that point to deal with recovery, especially if it was a severe case, like with the tension pneumothorax or anything like that. The physiotherapy there is going to be that we're working with them on the relaxation techniques for their breathing, controlling their respiratory rate, just making sure overall that they're doing everything they can to not overdo it for 3 weeks post-op because they're in recovery mode. So we're really trying to help them just rehabilitate at that point. The use of a spirometer is very important to help them build up that lung capacity again. And if the pneumothorax was severe enough and a chest tube was inserted, we might want to help them with that upper mobility. Again, just getting that back to normal, helping them understand their postural, cueing them to kind of be in the space that they need to be to open up that chest cavity, very much like what we were just talking about with Dr. McCrell the other day. And again, no exhaustive exercise 3 weeks post-op. If these patients had a chest tube present, when doing the therapy, we want to keep that negative pressure on the lungs at all times to help re-expand, or on the lung to help them re-expand it. So we would want to keep the drainage tube in the water, and we would want to make sure that the unit was on the floor below the thorax. So that's very important to note. Postural drainage techniques and kind of ways to help them teach them to work with a productive cough or getting themselves to cough productively would be to have them sit in a chair and put a pillow in their lap, fold it in half, and then just bend over that pillow. We could percuss them as indicated, depending. The other one would have them in a sideline position with their head down this way and their legs up this way. And then again, we would just percuss as indicated, depending on where that pneumothorax took place, or where that buildup is and where the drainage needs to come from. So I hope that this helps you guys in understanding pneumothorax a little bit more. I know it was a lot kind of in one little compact video, but if you have any questions at all, feel free to hit me up, and thank you so much.